Dr. Al Rameni is going to be talking about a conundrum that, thank God, we don't have so many of these patients in our lifetime. They're very difficult to manage. VSD following ACS shock, the use of percutaneous support as a bridge to repair. Dr. Al Rameni.
Good afternoon. My name is Dina, and I'm one of the heart failure surgery fellows here at University of Texas. And I'll be going over the use of MCS in the management of acute post-MI VSD. Post-MI VSD remains a catastrophic complication after acute myocardial infarction, causing a transmural necrosis of the septum. I quoted this from a study done by Dr. Schrag and Dr. Westerman. This is a computer model describing the PV loops and the changes that happen when there is an acute ventricular septal rupture. And as you can see, the RV volume and pressure, they go up versus LV volume and pressure, they go down. There's almost equalization of pressure in the two chambers with left to right shunt. The culprit vessel, most commonly, it's the right coronary artery. The second comes the left anterior descending, and then the circumflex artery. The anterior infarcts typically cause apical ventricular septal rupture, with the inferior infarcts causing more complex rupture, mainly basal. This is a table that compares mortality from different studies with historical data. Medical treatment of this complication has a mortality of 95 to 99%. And the surgical mortality has a range of 50 to 80% reported. And despite this high mortality, the surgical correction remains the standard of care. It's a class 1 recommendation. Now, the role of MCS in the post-MI VSD, it's a class 2A recommendation as of the European Society of Cardiology, with a level of evidence C. However, the guidelines do not specify a preferred form of mechanical circulatory support. So I'm just going to go over the different modalities. I'll start with the intra-aortic balloon pump, which is the most commonly used device. It decreases the afterload and subsequently decreases the shunt. And these are the computer models that, as you can see, there's really a subtle change in hemodynamics with the use of intra-aortic balloon pump, and a lot of times it's just not enough. For the use of Impella, I'm sure there's a lot of institutions that use Impella to unload the left ventricle. However, this is really the one study that I found in the literature, which is a 5-patient case series with a high mortality of 40% at 30 days. Use of ECMO, again, it's probably used. However, it's just in the literature, it's case reports here and there. The biggest is the upper one, which is a case series of 3 patients that survived to discharge with VA ECMO. The biggest take on VA ECMO is that it increases the afterload and subsequently increases the shunt, the left to right shunt. Now, combining ECMO with LV vent give us actually the best improvement in hemodynamics according to this paper. As you can see, the effects of ECMO in increasing the afterload are actually offset by the LV vent. So the combination of these two modalities give the best improvements in hemodynamic according to the computerized model. Now, moving to tandem heart. Tandem heart, it will unload the left atrium and direct the flow to the arterial system, so that bypass of blood probably in our experience has positive results. I quoted this paper, which we published at University of Texas, using tandem heart in 13 patients. And they also underwent delayed closure of the ventricular septal defect And the rates of survival, the 30-day survival was 83%, and the 6-month survival rate was 70%. Now I'm going to just go briefly about our experience at Memorial Hermann with the tandem heart. Over the last 10 years, we had 12 patients present with ventricular septal rupture and refractory cardiogenic shock. All these patients were bridged with tandem heart and underwent a surgical correction of the ventricular septal rupture. We had more males than females in this study, and the average age was 61. The etiology of heart failure was acute ischemic event, and 25% experienced prior ischemic event. The average size was 15 millimeters. Now, 55% of patients on presentation had an intra-aortic balloon pump, but then we escalated to tandem heart because they had refractory cardiogenic shock that did not improve with the aortic balloon pump, and 9% had Impella CP prior to having the tandem heart, and 36% had tandem heart upfront. Two-thirds of these patients had the tandem heart inserted within 24 hours of presentation. 2 of these 12 patients, upon presentation, they were in biventricular heart failure, so they received total artificial hearts. And these are just some intra-op pictures of the repair. We do a David repair at our institution. Our 30-day survival is 91.7%, and our 60-day survival is 75%, which is great compared to the results in the literature. Going over the culprit vessel, 75% of our patients had an acute RCA occlusion, and it was a culprit vessel, and 25% of them had LAD occlusion. Interestingly, you're more likely to die if you had an LAD occlusion versus RCA, which has a better prognosis. And about 60% had revascularization by PCI, and 25% had a concomitant coronary artery bypass revascularization during the surgical correction. The mean flow upon insertion of the tandem heart was 3 liters plus minus half a liter, and the average duration, they had it for about 12 days. I'm sorry, they had the tandem heart support for 17 days total, so they still had the tandem heart after the surgical correction to allow the myocardium to heal. Why did we choose tandem heart? There's a theoretical minimal risk of aspiration of necrotic myocardial debris into the pump, given that the pump is not going to be in the ventricle, so it won't be touching the necrotic myocardium in the septum, versus the Impella, which sits in the left ventricle, so it can be in direct contact with the inflamed myocardium, and a theoretical risk of microdebris aspiration. And the tandem heart does not cause right to left shunt, since the inflow cannula is placed in the left atrium, versus Impella, if it's running at a higher speed, it might actually reverse the shunt. And the tandem heart can be used in patients who have critical aortic stenosis versus Impella, which that may preclude the usage. And tandem heart is placed percutaneously versus the Impella, which 5, which requires surgical implantation. So there are no guidelines to support a preferred method of mechanical circulatory support, and the hemodynamic optimization and using pharmacology and MCS in the form of tandem heart in our study is showing promising results. And is it worth revisiting the guidelines of the optimal timing and the unified form of mechanical circulatory support in these subset of patients? And that'll be it. I would like to thank Dr. Salas and Dr. Jumian for their mentorship.
Dina, do not worry. We were not going to let anyone stop you. I mean, what I loved about you, I learned a lot from your talk. I loved seeing that if this obtains, this model of using tandem, it certainly proves a point that, you know, like in the babies with VSD, the volume load is acutely unsustainable in the LV. So an LA decompression is just an amazing strategy because you have a whole mess in the LV. So I'd love to ask our panel thoughts, and I think her last question was, does this call for maybe some strong input on guidance? Because I mean, again, we take care of some VSD patients with our surgeons, and we're always trying to make up what's best for the patient, but this is some great data for us to see.
The question is it sounds like your strategy is to put in the tandem heart surgery immediately after they've recovered from the shock and then rest them further afterwards, as opposed to some strategies are support them for 2 weeks, let the tissue heal, and then do the VSD repair, right?
Well, we do support the delayed surgical correction. So we advocate for putting the tandem heart for at least 5 days to let the myocardium rest and then have a surgical correction. And they would still have the tandem heart after the surgical intervention.
Yeah, I mean, I certainly sympathize with my surgical colleagues. I don't want to put sutures into mush. But sometimes I feel like some of these really sick patients, we kind of let the really sick ones die off, and then we take the patients who are lower risk to the operating room, which may be appropriate, right? I'm not saying that that's necessarily the wrong thing, but I still am unclear exactly, when do you take them, right? Particularly if you unload them aggressively and early, and their hemodynamics look good for 5-6 days, from a surgical standpoint, like how soon can you go? I mean, what are you looking for at the end of the 2 weeks? Was there something at the end of 2 weeks that you said, okay, they've met these criteria, and so now we're going to take them to the operating room? Was it just sort of an arbitrary time point? Were there goals in that?
I mean, Jeff, some of these patients were closed percutaneously, which is interesting, but I'll let Dina, speak. I mean, that's an interesting question.
I think from a surgical perspective, the rationale behind waiting is to wait for some scar tissue to form versus sewing in an inflamed necrotic tissue. I think that's why we say 2 weeks, because that's when the scar tissue starts.
So maybe I can just throw a provocative question for the people that can't wait for 2 weeks. What's the best?
And you're saying can't wait because that platform is I mean, they're kind of like tree topping.
Yeah, so that they're maybe they're sicker, or what if let's say that it's a smaller person and they're having issues with their cannula size and perfusion or some sort of mild hemolysis, but their hemodynamics are looking okay now, but they haven't made that 2 week time point to kind of really form scar that you can get something into. What's the temporizing thing to do?
So in these subset of patients that you're describing, we did take them earlier to surgical intervention. Okay. So if we see that there's like clinical evidence or lab data that is showing that they're not improving, we did take them earlier.
Could I ask Dina, maybe if Biswajit or the colleagues here, have you had to change platforms from the tandem? That's one question I had. And the other is, have you had a chance to just look at the patients that how they did long term? I'm just curious, even the long term data on these guys.
We have long term data, she said, at 6 months, it's about 75%.
Okay.
But we have had to change twice. I remember this is a small series, you can make recommendations, this is a small series. But the two we changed was one of them actually, that's the one who survived, had to have a tandem heart, and right in front of us, Dr. Gregoric, I think is in here, we were standing and the patient went into electromechanical dissociation and had a free wall rupture. So as soon as the free wall rupture, we were standing there, all I did was pull the tandem into the right atrium and put it into a ECMO configuration, went straight to the OR. She actually walked out of the hospital, one of the only one I have seen a free wall rupture walking out. So that was one, we had to change the configuration to a VECMO. And second was developed a clot in the left atrium cannula of the tandem heart. So that one we had to again pull.
So I'm glad you mentioned that free wall rupture, because we've had the experience of free wall rupture with VSD, and maybe that's to the point that Jeff is making. That could happen 4 days later, and if you weren't there, the next questions or anyone else. I mean. But I do think this is an interesting, real question for us. We have a question from the floor here, sorry.
Thanks so much. Faraz Masood, cardiac surgeon from St. Louis. This is a very interesting talk, and I loved it. I think the penetration of tandem heart is not as universal across institutions, whereas ECMO and Impella is readily available. Impella rep could be found literally on my left side if I turn around. So if tandem heart is not available, then what is a recommended second line of mechanical support. And I agree with Dr. Tuderberg that I think it's not the development of scar tissue and a little bit stronger myocardium to sew, but the better the patient going into the operating room, the better the patient comes out of the operating room. And we would always keep these patients on some degree of mechanical support to keep the LV unloaded. So great talk, I loved it, thanks.
Thank you. I think that's the point. The point to be made is that there's no recommendation on which MCS device to be used. Now, we have a good experience with Tandem Heart. If my personal opinion is that ECMO versus ECMO plus Impella would be the second in line, but I'm no expert in the field, so.
Because they always come with a balloon pump from the referring hospital, and then we have to scratch your head at what do you do next.
Great, thank you.